Good morning, good afternoon, and good evening, everyone. My name is Matthias Gröschel, and I welcome you to today's webinar. These webinars are co-organized by the ITU-WHO Focus Group on AI for Health and the Department of Biomedical Informatics at Harvard Medical School. These webinars are being held under the umbrella of AI for Good, which is the UN's leading initiative around how AI can help achieve the Sustainable Development Goals. If you're interested in learning what the focus group or AI for Good is doing, please reach out in whatever way. In this series, we try to cover relevant aspects and challenges in data-driven research, and I have the privilege of introducing today's session, AI in Health and Medicine by Zak Topol. Today's session will be moderated by Dr. Zak Kohane. Zak is the inaugural chair and professor of pediatrics at the Department of Biomedical Informatics at Harvard Medical School. He's a trained pediatric endocrinologist and received his PhD in computer science during the second heyday of machine learning at Boston University. Zak believes that medicine at its core is a knowledge processing discipline, and as a result, his research agenda has been focused on leading several large international efforts to leverage the healthcare enterprise for discovery and new insights. But most of all, Zak is a really great mentor and a role model for many of us young scientists. With no further ado, I'll hand over to Zak and let him introduce our speaker today. Thank you.
Well, thank you, Matthias, for that kind introduction. And it's really a pleasure to introduce Zak Topol. I think Zak is extremely well known among most of you. Indeed, he has, if you look him up, he's done an amazing amount of science and scientific leadership. He's the founder and director of the Scripps Research Translational Institute and is a professor of molecular medicine and executive vice president of Scripps Research. He's led important projects at the national level, all of us. He has shown early awareness and expertise in a number of cutting-edge areas in medicine, from use of portable wireless technology all the way to AI, and has featured prominently the importance of providing patients with their own autonomy and agency in this process. And he's written 3 books, at least that I'm aware of, on these topics. But I have to tell you, those impressive achievements are not what impresses me the most about Zak. The thing that impressed me the most about Zak is actually something that goes a bit far back, which speaks, I think, to being a doctor, and being a doctor who is responsible for your own patients, and responsible for other patients. And so early on, Zak became aware of some potential complications and side effects of the use of a drug, Vioxx, which had some nice properties in terms of having pain relief, but ended up having a significant cardiovascular risk. It's not a popular opinion to have initially. And, it's a lot easier to be gung-ho about AI when everybody's thrilled about AI and excited about AI than it is to be talking about a new drug that a lot of people like and say, watch out, that's a problem. So that, in my mind, is a real measure of Zak, in terms of doing what's right, taking a public stand that's unpopular, but really letting the data drive what we recommend to our own patients and to policymakers. And so in that respect, I do think that Zak's views are informed, even in AI, by these same lodestars. And so I'm going to welcome Eric to talk to us about AI, but I'm actually going to start with a question. I didn't prep Eric at all, and Eric, feel free to ignore this, but back in 2016, we were very, very excited about the revolution that AI is going to have, and in the changing the way, particularly how we're going to be interpreting images from the retina to chest X-rays. I'd be curious to see what your level of excitement, more specifically, where do you think are the challenges that we need to overcome in order to make this actually happen? So anyway, Eric, thank you very much for doing this. I look forward to your talk. I'll be quiet. If you run out of words, I'll certainly goose you with another question.
Well, thanks so much, Zach. A really kind intro. And I don't know if there's anybody in the country I look up more to in AI and medicine than you. So it's really great to join you. And I definitely will respond to that question. That's what I've been thinking about a lot. Let me get my slides up here. And we good there?
Yep, looks
okay, good, thanks. All right, so when Zach and Matthias asked me to do this kind of roundup on AI medicine, I wanted to mention that we've been keeping up every week, first with Pranav and now Emma. And this is the so-called Dr. Penguin. Don't ask me why it's called that, because Pranav picked that name. But basically, every week we highlight the top AI in medicine, biomedicine papers. Usually it's an average about 5, sometimes as many as 10. And they're annotated and the links are provided. And so basically, it was very easy to prepare a review article for Nature Medicine that appeared earlier this year based on this, because we're all over this trying to curate the best new research. And this is the Nature Medicine paper. And I wanted to deal with this circular diagram because that's kind of what I'm going to get into today. So as Zach has already introduced, the sweet spot right now for AI in medicine is medical image interpretation, which is going to be a lot of what I focus on. But that has interactions about how are we going to deploy, in that upper left quadrant, deploy AI in medicine and implement it. So those different quadrants of this wheel, if you will, or circle, I'll get into, including ethical issues. I'm not going to get into the non-image data source, multimodal, which is really the next frontier. We have a new review focus on that, and also on unsupervised or self-supervised learning. That's another important next wave. We have a review forthcoming on that as well. But with the time we have at hand, I didn't want to overstep what we can cover reasonably. So Zach already mentioned the retina. And I just want to go back just a second about, it's not about just accuracy. That is, we can really rev up accuracy of interpretation from human experts in medicine. We can go well beyond that. And I use the retina first as the indicator of what's ahead, because as we looked at the retina for all these years, we didn't imagine that it would be a window into kidney disease, into being able to track the glucose control or blood pressure control, that it may be our best indicator of early Alzheimer's and tracking the disease and other neurodegenerative diseases, that it can tell us when and if to intervene for macular degeneration, but even as much as liver and gallbladder disease. And imagine that you could get the heart artery's calcium score through the retinal vessels. All of these have been achieved through deep learning. So this is not just about accuracy. This is about using machine eyes, if you will, to derive and impute things that were unforeseen just a few years ago. And so the idea that you could predict a heart attack risk from the retinal photos, as recently published, is very intriguing. Of course, more work has to be done. I don't think anybody would be too excited about an AUC of 0.8, but it's certainly something that we wouldn't have conceived possible not long ago. Now, as a cardiologist, I turn to the cardiogram because that's something I've enjoyed reading for many decades. And I would never have been able to determine the age and sex of a patient through their cardiogram, no less their hemoglobin value accurately or their ejection fraction. Also, not miss critical diagnoses that the deep neural networks can pick up, like pulmonary artery hypertension, hypertrophic cardiomyopathy, amyloid of the heart. So this is really exciting that we can have such enhanced interpretability beyond just the basal ways that we look at a cardiogram. And it goes much further than that. Now, just looking at a 12-lead cardiogram, we could predict pretty well into the future as to a person's risk of atrial fibrillation. And we know that those risk factors, such as obesity or heavy binge drinking, can be risk factors for atrial fibrillation and warn patients to prevent them having this arrhythmia. But it goes beyond that too, just like with the retina. Here we see that you could actually be able to impute the filling pressure of the left ventricle, that is the pulmonary capillary wedge pressure, from the electrocardiogram. I don't think I would ever have conceived that to be possible. Again, an AUC of 0.80 is not as high as we'd like to see for performance, but this will get better as we get millions of annotated electrocardiograms with accurate concurrent filling pressures to train neural networks. So the Mayo Clinic has been a leader in this space. They have already incorporated in their clinical care of patients. So when a cardiogram is interpreted, it isn't just the old heuristic rules-based interpretation, but rather it will say, what is the ejection fraction? And here's an example of how that made a difference in a 35-year-old man who had no symptoms, who had a sister who died suddenly, and it picked up and predicted that the ejection fraction was critically low, and indeed by echo it proved to be 18%. It would have been missed by clinicians because that's not possible, even by expert electrocardiographers. Now, more work has been done that's really exciting. I think those of you who follow cardiology may not be aware that implantable cardio defibrillators, ICDs, are frequently implanted using crude clinical criteria like ejection fraction less than 40%. But it's striking that 90 to 95% of these ICDs never are utilized. And they're very expensive. They have lots of potential complications. It's a lot of hardware to have in a person's body. Well, now the group at Johns Hopkins just recently published this month that you could predict using deep neural network interpretation of an MRI scarring, the real risk of a person, the real need of a person to have a benefit of an implantable cardio defibrillator. So this is really exciting work. It's still in the early phases because it's derived retrospectively, which I'll get into shortly as one of the major limitations. And in a form of semi-supervised learning, this is cluster analysis to determine which patients benefit from beta blockers who have heart failure, because beta blockers are given very broadly, but certain people, as shown here, people of advanced age and sinus rhythm don't benefit from beta blockers as determined by 15,000 people with ejection fractions of less than 50% with heart failure. So this is interesting, and this cluster these groups have been validated in this study just recently published in 9 independent trials. So we're learning a lot from this type of analysis on how to treat patients with heart disease better, potentially. What about pathology? This is striking because if you look at a slide, and this is whole slide imaging, digital, a digital slide that is very different than the typical H&E slide. because now you have all the pixels that can be picked up by a machine learning. And it's striking because when you train a deep neural network, you not only can determine what is the origin of the tumor, which is not infrequently uncertain, but you can determine driver mutations, the prognosis of the patient, structural variants in the genome. This is just a study from 17,000 slides and over 10,000 patients, but it's been replicated time and time again. So the whole slide image is rich, extraordinarily rich. It just exceeds what human eyes can pick up. And so in the cancer space, while we're on that, we have this CT ability of a lung to also be trained through neural networks to pick up whether that person has a favorable genotype for treatment. I mean, this is again like that pathology, driver mutation determination on a whole slide image, but this is now through a CT scan. And this is from over 18,000 patients with lung cancer in 6 countries and further validated. So this is striking that we can actually train the eyes of a algorithm or a deep neural network to pick up a mutation that humans couldn't see. Now, this is a little fidgety here. Mammography is one of the most used screening tools we have in medicine. And it's notorious for false positives. And indeed, for women over 50 to getting 10 years of mammography, over 60% at some point along the way of annual mammography will have a false positive test. So this MRAI algorithm that was worked at Mass General and validated further in Sweden and in Asia actually was very good at predicting 5-year risk. It was determined through retrospective studies, and interestingly, it has led to the idea that we can revolutionize breast cancer detection with far less false positives and also false negatives. So this is an idea we'll come back to in a moment because it looks like it may indeed be premature. Ultimately, we will likely get there, but we're not there yet. But what we are missing a lot of data. So if you just look at these recent studies from this month and last month, in the abdominal CT, when it's interpreted, who would have thought we could say if a person has high likelihood for type 2 diabetes by looking at their pancreas? Or in a mammogram, who would have guessed that we could look at the breast arterial calcification and then be able to indicate the risk of that person having heart disease, which is frequently missed or misinterpreted in women, particularly postmenopausal women who are at risk for heart disease. Now, it isn't just these picking up things in the image, it's also what to do with images in the clinic. And this is a really nice study, was just reported from Northwestern Medicine, where they have an enormous number of studies, in fact, 570,000 lung or adrenal imaging studies, and they trained a neural network as to the ones that are flagged to get the results to patients quickly. And so using AI to streamline the workflow and particularly to inform patients, and this is a quick, very ideally working model that many health systems could mimic or simulate to improve the flow of information to patients, which frequently is associated with marked delays or even missed communication. Now, I touched on this problem in medicine, that there is very few prospective studies. Almost all of thousands and thousands of studies of AI in medicine are retrospective, in silico, with ideal, pristine data sets. But the real world of medicine is different. And these are the only studies that are prospective. And you can see they're very limited, and they're only in about a handful of disciplines within medicine. And even more rare, I'm not sure why jumping slides, but even more rare is the issue of randomized trials. These are the full table of randomized trials. And you can see most of them are in colonoscopy or endoscopy, most of them in China. And there's just a few others. The slide jumped, but it was a Mayo Clinic that actually looked at the use of electrocardiograms, a randomized study for picking up ejection fraction in primary care physicians. And it showed to be more accurate, as you might have surmised. But you can see there's very few studies of randomized trials, which is what we need to provide compelling evidence. I just want to mention that AI for Good, since that's the title of the programs that you are putting together, it can help people who are blind. This is a multimodal AI for people who are blind to improve gait, functioning somewhat like a driverless car in terms of interpreting lots of data in real time to provide guidance for a person who's blind to not have issues of mobilization, ambulation. And similarly, those who are deaf or impaired hearing, using AI to be able to help provide auditory signals for these people. So there's a lot of good things that are happening in the AI space for health and medicine. And I think this is a really insightful recent essay that has nothing to do with AI and medicine, but actually has a lot to do with it, because what we have talked about are tasks that humans do, that is clinicians interpreting images, and that we are seeing algorithms that could automate those tasks. But what I've tried to stress is that we are seeing things that are beyond that, that humans can't do with the help of machines, that we couldn't possibly have the ability to interpret all these pixels accurately to come up with these things that would be otherwise previously considered far-fetched. And ideally, of course, we have the fusion of these, as I'll get into. Recently, last year, there were our Consort AI and Sprint AI, very important guidelines for performing AI research in medicine and reporting it, publishing it, disseminating it, coming up with very responsible templates for what would be considered appropriate, acceptable. And these are really important because it only took a couple of years to come up with this consensus. It's worked at by the University of Birmingham in the UK with over 200 investigators throughout the world. And this template is important because all the leading journals will follow it. It took nearly 20 years to do this for medical research in general, but it's only taken a few years to get this groundwork, this foundation laid for the AI and medicine space, which is really a welcome progress. Now, it's frustrating here. This slide is to take us to the next segment, which is in AI, we have this ill-conceived notion that there's this problem, it's an input, and we get a solution. But it isn't quite that way. And there have been many disappointments already in AI. I'm going to just review a handful of them briefly to put in context that there's all this excitement, but there's equally, to stress, many disappointments so far. The first, since we're still in the midst of a pandemic, which a lot of people think is over, but I think it's far from over. But the pandemic brought us the question, could AI make a difference? And one of the big areas of concentration, because we talked about imaging, was to use AI to make a rapid, putatively accurate diagnosis of COVID via chest X-rays or CT scans. And this was a systematic review of over 2,000 papers. It got into the 62 that were thought to be the best of those papers. Not a single one met the criteria of a sufficiently documented paper that was reproducible, that follows best practice for developing a model, or had sufficient validation to justify use. None of the models identified our potential clinical use, none. was in the paper, the term Frankenstein data sets were used. And this was furthered by other reviews in the BMJ and also by the Alan Turing Institute to basically show that we're not there yet. And to the idea that we could use a CT scan or a chest X-ray instead of a PCR to make a rapid diagnosis of COVID was completely unvalidated, non-validated. I mentioned mammography. So that was reviewed last summer, and all the papers on mammography were reviewed. And the conclusion was, in a retrospective test, all these were retrospective, 94% of AI systems were less accurate than the radiologists, and all were less accurate than the original consensus of 2 radiologists. So that doesn't mean we're making a lot of progress now, does it? So Connie Lehman, who is leading radiologists working in AI in Boston, Mass General, I'm sure Zach and many of the folks there know well. And I wrote an essay in the Lancet about this. And the main conclusion was the fusion of machine and expert human vision is the combination that needs to be emphasized. That has not really been the focus of these studies. As I mentioned, they're all been retrospective. The promise of AI has not been diminished by awareness of the limitations that this review brought out. And eventually we'll get there, but it's going to require compelling evidence from really high quality, rigorous prospective studies in large cohorts. And we're not there yet. So this revolution in AI for mammography hasn't even started. Now, what about colonoscopy? Because I mentioned that's where most of the randomized trials are, picking up polyps, even saying whether they're cancerous, likely cancerous in real time to either prevent or induce the need for a biopsy. And this is used now, real-time colonoscopy in many Asian centers in Japan and starting to be used in the US. How well does it work? Well, this month, last week, was a paper that said, not so great. And in fact, the AI compared with the standard diagnosis was not significantly different. The confidence level of the clinician was increased, but the actual hard data in a study that was conducted through centers in Norway, Japan, and the UK in almost 900 polyps and over 500 patients, there really was no difference. So that's a real world test of real-time AI during colonoscopy. Disappointing. Then there's sepsis. This was a hype article that appeared earlier this month in the Wall Street Journal. How AI saves lives in the ER. And it's all about how AI picks up sepsis that the clinicians miss or better manages the sepsis and saving lives. Well, not so fast. In fact, STAT put together what their review about AI gone astray and how there are shifts in patient data, and these popular algorithms are undermining, not improving patient safety, undermining patient safety. And so just last week, we wrote an essay about digitizing using AI for sepsis. And it's in the Lancet. And I can just say that this is the conclusion of that. AI remains an unfulfilled technology in the battle against sepsis. Its potential is promising. Hopefully we'll learn from these missteps about data set shift. We must remain vigilant to prevent patient harm or overhyping this complex technology. So these are disappointments. And as you would expect, there's not a lot of implementation of AI in the clinic yet. It's largely in radiology. Those algorithms have not been made transparent. Clinicians don't, and even health systems that buy them these are proprietary algorithms get 510K clearance by FDA, but they're not available to their performance and the algorithms themselves. They're not open source to clinicians and health systems. So that's a credibility crisis. And we recently wrote a essay about the gap, this chasm between the studies that have some validation, and why are they not getting implemented clinically? One notable example of how it should be done was radiation therapy that Rajesh Jaina has introduced in the UK. And hopefully we'll see more of those that are fully transparent and fully validated in the times ahead. Ziad Obermeyer has set up with a lot of collaborators an open science for medical imaging to enhance large-scale annotated image data sets which are deficient. And that open science is something we desperately need in AI. We also need trust. This is not the case in AI we trust. We don't trust it because we're looking after patients and we want them to be better treated and not ever compromise their safety. And so a lot of work needs to be done to improve this. And let's see if I can get this right. This is just jumping for some peculiar reason. So we can improve these algorithms. The inputs, this is from our recent review in Nature Medicine. We can have multimodal data, which will enhance the inputs. We can also have large-scale annotation or switch, as I alluded to self-supervised or semi-supervised approaches. This is a significant issue in medicine, is a limited number of data sets that are well annotated at scale. We can also get away from all these retrospective studies and get into much more real-world clinical deployment, and also study the AI-human fusion, the collaboration, rather than just pitting humans versus machines. Just jumping. So another part of AI in medicine that does not get enough emphasis is giving patients more autonomy. Zach mentioned this in his intro, and this is something I'm a fervent supporter of, but obviously has to be done right. The first foray into this, interestingly, was the diagnosis of atrial fibrillation through a smartwatch deep learning algorithm that's focused on resting heart rate and when it is abnormally high in people who are at rest. And that prompts getting an electrocardiogram or one lead that can diagnose pretty accurately atrial fibrillation in people who are at risk. And unfortunately, this app is widely promoted mass use, and a very few people actually would benefit from using it. But the same setup for patient screening of skin lesions, rashes, skin cancer, urinary tract infection, which is already used widely in some countries like the UK, a kit that you can pick up from the pharmacy that accurately diagnoses whether you have a urinary tract infection, diagnosis of ear infections in children, diagnosis of diabetic retinopathy by an untrained person with a system that can be now set up in many grocery stores around the country for a diagnosis that's not even ascertained in half people with diabetes and is the leading cause of reversible blindness. And we're seeing algorithms that support people, coaching them. They're not holistic. They're in specific areas like hypertension or in glucose regulation or in depression. But many AI algorithms are now getting legs to use data to actually provide some virtual health assistance. Many are integrated with backup human coaching as well. And eventually we'll get to this stage. It's going to take years, but it's actually very exciting that you could prevent diseases or conditions that a person was otherwise highly at risk for by having all their data processed and fed back to them to help prevent or better manage a condition in the years ahead. This will require hybrid models that don't even exist yet because it's a real challenge of multimodal AI, which we have not yet met, involving multiple sensors with continuous data and all these varied inputs. Now, there are a lot of ethical challenges in AI. I've already touched on some of them, like the distrust and uncertainty, like the regulation, that the way that algorithms get cleared by the FDA, but no one gets to see them or really understand the level of their performance. The responsibility in using AI in practice, that is the safety of medical AI, the privacy and security I'm going to touch on here, and then biases, lots of biases that are embedded in the data, and not as much, but also in the algorithms. So this is just a recent number of reports that gives us that uncertainty sense about the big chill, about all the tools that were supposed to catch COVID, none of them did. We don't trust AI. It needs to be explainable. That's also debatable as how important explainability is. But nonetheless, these are some of the issues looming over the future of AI that need to be grappled with. So this particular report is probably the best that's out there still from the Harvard Berkman Klein Center, that goes through all the issues about principled AI and features all the things that I just mentioned, really. And just to go further with this, privacy, there may be AI solutions for privacy. Now, this started with, this is also from our review, the idea of using federated AI. But the federated AI model requires a central command post coordination. And that, of course, could be an issue with respect to compromising privacy. So more recently, in fact, the idea of using not just federated learning, but rather swarm learning has come into play, which is basically computing at the edge. And not sure why we're getting these skips, but swarm learning, which was last June a cover of Nature, using basically edge computing and a blockchain platform for preventing even the central coordination and having privacy assured at the highest level that we know of today. And so this is exciting, and it was just this week brought out by this paper of being able to pick up colon cancer, over 5,000 patients picking up specific BRAF mutations, and swarm learning outperformed the locally trained models and eliminated the need for data transfer. So swarm learning is getting legs, and this is just one of the very recent, as of this week, examples of how it may come into play, so that the new privacy computing techniques may help get around this concern. Now, what about equity, inequities in particular? And this is something I think is really exciting, is the use of AI that bridges remote parts of the world that are low and middle income countries, to give them advanced technology. This is an example of using smartphone ultrasound here to diagnose pneumonia in the lung, but it can be used in any part of the body except the brain in any part of the world. And this is my favorite tool in medicine, which for me replaced the stethoscope years ago, smartphone ultrasound, whereby the probe is attached to the base of the smartphone, and within seconds, you're imaging any part of the body, as I said, except for the brain. And of course, as a cardiologist, I love to see the heart immediately and share it with the patient, seeing every aspect of the heart in motion, the strength of the heart muscle, the thickness, the valves, whether the valves are leaking, everything immediately that I couldn't detect with reliability through heart sounds. And this is now AI with smartphone ultrasound, because with the idea that you could take a person who has no training of getting an ultrasound and using AI to direct that person to acquire the image just by AI telling the person move the transducer up or down or clockwise, counterclockwise, and auto capturing the video loop when it's in the optimal position. And that's what's happening now. AI acquisition by people who have no idea of how to do an echocardiogram, no less a ultrasound of any other part of the body, and auto labeling and auto interpreting the study. And so this this is an area that I think is just getting started in AI, but the idea that you could get anyone to acquire an image and get it auto-interpreted is getting a lot of attention right now. And the heart is the most complex one because of its being in motion. And I, some couple of years ago, actually imaged every part of my body except my brain, sort of a medical selfie, and all the way through kidney, gallbladder. I had never even imaged these parts of the body. I had to look them up on Google, and within seconds, I could image virtually any part of the body, all the way down through the popliteal faucet down to my left foot. So that's where we can go with AI. People with heart failure will have monitoring their heart through their smartphone in the future, looking at their cardiac function. When these transducers that connect to the smartphone become remarkably inexpensive, which they aren't yet, and anyone can get deep neural network guidance of how to acquire first-rate medical images and even get the preliminary interpretation. And since we're on the AI for good theme, I do want to mention this end of March, just last month, this cover paper on using AI to improve in low income countries, using the mobile phone data to improve humanitarian assistance, like, for example, food insecurity, how to respond to that. And this was pinpointed through the use of AI. So there are a lot of examples of AI doing good in health, and especially in parts of the world that we don't focus on enough. Now, I just want to end with this, what I consider the most far-reaching aspect of AI in medicine, and which is the theme of the book I wrote on deep medicine, which is fostering the human connection, returning the precious aspect of that relationship of the patient-doctor, patient-clinician. We do not want the robot to see us now. That is the last thing we need right now. And I was fortunate to be asked by the UK government to provide oversight of a review of the NHS, especially on how it would use AI and digital and genomics for the future of healthcare in the country and also on the healthcare workforce. And what was interesting is this big group that I got to work with of over 50 transdisciplinary experts from the UK. The thing that we came up with that had the most striking impact in the near term was getting rid of keyboards, keyboard liberation, how even just 1 minute would reduce the toll of clinicians, no less the number of clinicians or their disenchantment, and restore the patient connection. So, in fact, there are many companies working in this space. The big acquisition of Microsoft of Nuance is one exemplar, but many other, both tech titans and startups, are trying to achieve keyboard liberation with synthetic notes, replacing human scribes, replacing the need for clinicians to have to work at keyboards to enter data. And that certainly can be accomplished. We already have some really excellent examples of where this is headed. And this whole idea of restoring the joy, which is, of course, not the sense for most clinicians today, to the practice of medicine. And that's one of the ads with respect to where the future can take us in keyboard liberation. And already we're seeing AI with natural language processing help the communication between physicians and patients. And this is a study from Kaiser Permanente with emails and trying to get rid of the poor wording, the inside baseball wording to patients. So this idea that we are like system one thinking of Danny Kahneman in medicine, reflexive without thinking. That is the idea that we are fast and shallow. We need to do better. And Daniel Ofri, who is one of the really great authors on this topic, talked about the beyond the financial waste, the modern medical practice is a petri dish for medical patient harm and physician burnout. So how can we get this on track? It's a gift of time. That's really what AI can get us. It can get us not just keyboard liberation, to better synthesize all of the patient's data that's available, to do some primary screening, to streamline the workflow in examples I've mentioned, and also to give the patients much more charge and much more engagement in their data. And so there is no algorithm for empathy. And I'll just leave you with this last slide, which is this incredible paper, this Francis Peabody, 1927. So it's almost 95 years old, but it's as true today as it was then. I'll just go to the closing paragraph of this 5-page paper. It's inspirational, but what it says is that one of the essential qualities of the clinician is interest in humanity, for the secret of the care of the patient is in caring for the patient. And that's where the counterintuitive sense is that AI and technology could actually enhance humanity and enhance the care of patients and get back the mission of medicine, the essential aspect of the patient-doctor relationship. So let me just acknowledge all the great people I get to work with and our funding sources, and turn it back over to you, Zak.
Thank you, Eric. That was really great. And I have to say, I already learned a lot, so I really appreciate it. So I'm sure everybody else learned a lot as well. There are several questions, but you actually touched on one of my favorite pet peeves. So I'll take the privilege of being moderator to ask my own question, which is, I won't say which medical schools, but there are many medical schools where the students are asking, why am I learning how to palpate and use a stethoscope? And there's this commercial ultrasound thing that would allow me to see much more. And what do you think is getting in the way of this becoming medical school first year introduction to the clinical exam?
I'm so glad you asked that, Zak. This really is this entrenchment in medicine. So the attending physicians, the teachers, have no clue. They haven't adopted the new technology. They don't realize where this is headed quickly. And the students recognize that the stethoscope is like a buggy whip. You know, it's really of limited value. Yeah, I mean, we're still going to use it to check when you intubate a patient that the tube is okay. It has limited use, right? And it's cheap. But the tool of a smartphone ultrasound probe is unbelievably powerful. And it isn't being taught in medical schools. I think there's 2 medical schools out of 150 that have it in their curriculum right now. And when you and I went to medical school, you know, stethoscopes were like given out as, you know, that's the tool, and it still is, you know, worn around the neck and in the pocket. And that's what should be done now. But our medical schools change their curriculum like a battleship changes its direction, you know, and it's just incredible.
So Eric, you're a disruptor. So tell me the one thing we could do. What do you think is the one thing we could do that would say to a dean of education, you know what, we probably should be teaching that?
Well, I've talked to the AAMC, you know, at the dean's meeting, and I said, you got to do this, and they won't do it. One thing they've gotten into, interestingly, is they have figured out that telehealth was going to be important. So they're training students to doing virtual consults. Mm-hmm. Okay, that's good, but they haven't started on this one.
Amazing.
And it's frustrating. I have to say, though, in my clinic, which I have every Thursday, every single patient has a smartphone echocardiogram and a fingertip 6-lead, actually ECG, as part of the exam, because that's the kind of stuff that's free now. And I hardly ever have to do a formal echocardiogram. It's so much cost savings involved. So this is the other thing about it, Zak. It isn't just that it should be the standard of care, but it actually preempts so much of the expensive, you know, the 45-minute formal ultrasound studies that are just, you know, a ridiculous overuse.
Well, so that's absolutely right. And if we're going to take the what you just said, which is that gift of time seriously, part of it is getting familiar with the tool, so you know how to interpret, you know, in context what it means. And we're not except for people like you, we're not getting that that experience that we used to get with a stethoscope looking at every single patient.
Yeah. Yeah.
Anyway.
And what's interesting is if you do a careful cardiac exam, that takes by stethoscope and palpation, that takes longer than the ultrasound exam too.
Right.
And this whole idea is, I don't get reimbursed, well, I don't know how to do it. This is just, it's not acceptable. We have to.
Well, I raised that because it's truly one of my pet peeves. And it's embarrassing for me when my students, medical students, ask me that question. I don't have a good answer. And second of all, it's, I think, important for our audience, the non-medical part of our audience, to understand where the medical establishment stands. And because that, in fact, that inertia is one of the biggest, sadly, blocks. So now, although you and I could just enjoy talking to each other for the rest of our time, I'm going to look at the questions from the audience that Matthias has paraphrased for us, and I'll run them by you. So let's see. Question number 1 by Aisha Chowdhury. Okay. Within context of variations of norms which also impact our assumptions, how does AI address it? Transformation. Don't understand that question. Yeah, sorry, Aisha. It's not too buzzwordy, and I apologize. Fred Werner. Could AI be used to identify new drug treatments by combining knowledge of Western and traditional Chinese medicine? Okay, that's interesting. What do you think?
That's certainly possible. I mentioned the idea of being able to figure out, instead of the way we give everybody beta blockers who has heart failure, that we could start to zoom in on who really does benefit. Eventually, we're going to have these digital twin infrastructures that will help, and then we can look at all these sorts of things like non-traditional medicines, but we're a long ways from that now.
I agree. All right. Question number 3. Your book, Deep Medicine, was published 3 years ago. In those 3 years, which progress in AI health medicine, or which lack of progress, has surprised you the most? So you already shared your negative surprise, which I shared also, about how unhelpful it was in COVID. What other surprises, positive and negative, have you had?
Yeah, I think the main positive thing has been going beyond accuracy to using machine eyes to see things we never would have conceived possible. But these are all, the potential. The main thing is not much has changed in 3 years. I mean, really, beyond that, we aren't seeing, a lot of prospective studies or randomized trials. I think there's a few, but the one I mentioned about Mayo Clinic and how they have implemented the ECG as a routine, enhanced interpretability is just, but there's few of those examples. You and I, Zach, have watched the Rady Children's Genomic Institute and how they're using many AI tools to look after sick neonates to get a rapid genome sequencing with AI. That's a model program that wasn't in full gear back in 3 years ago. So there are some of these, what you call like very specific examples, but they're few and far between, unfortunately.
Well, that's good. It's good that you reminded us, because in fact, I think interpretation of genomes is actually a classical, at this point, case where humans just don't have the memory, the ability to sift through all those variants. And it is a no question effective use, but it's, as you said, narrow for the moment. All right, this is something that's also up your alley, since you've been a proponent of this. How can we support data donations from patients and people in general to contribute to the development of AI for health? So I'll say 2 comments. We've seen a very successful data donation in UK Biobank. Other efforts have been less successful. So what are your thoughts about that?
Yeah, this is a big issue. The UK Biobank is the model for the world of how, the productivity from that has been extraordinary. It's been far less to date from all of us, which is the most ambitious medical initiative ever in this country, medical research initiative. Part of the problem, I think, is not having broad entry. That is, right now, digital access people who want to be participants and clinical scientists, citizen scientists. There's this great enthusiasm out there for people who don't have a background in science or medicine to be a participant, and appealing to them and making it broad rather than in specific health systems with bringing the people in the clinic and having them fill out hours of surveys and doing a physical exam, which is basically worthless. There's a different model to do this, and we're not tapping into that model. And I hope we'll see more of the new way of getting broad participation in millions of people. The one good thing about all of us, as opposed to the UK Biobank, is it has a diverse sample, has about 400,000 people. About half of them are underrepresented minorities, but we have to do much better.
Okay, well, wow. All of a sudden, we get a lot more questions. And now I'm looking at the clock. We have 3 minutes to the top of the hour. Okay. All right. This is a really interesting question from Alex Hoffman. Should medical practices begin creating their own AI expertise in training models? Or should we be looking at partnerships with technology companies and private enterprise as a better way forward? So you've been involved with companies, you've been involved with, and are involved with clinics. If you were honcho of a clinic, would you be saying we should be developing our own expertise? We should be partnering with companies? What would your advice be?
Yeah, I mean, I don't know if there's a right answer here, Zach. I mean, I think certain algorithms may be better locally, but I think if you're going to go to all that work, instead of having other institutions having to recreate the wheel, it'd be great to combine forces. I think the new privacy computing may alleviate our concerns of working with companies. I think there's a lot of antipathy about working with a company, like for example, when Mayo Clinic and Google and the Microsoft things that have happened, it's led to concerns about privacy. But I do think that hopefully there's going to be a better workaround plan for that. But I think the idea that if you can work with multiple health systems of diverse patient populations, the work that you're going to do is just going to get better. This idea of working with a single system has some appeal because you have control and, the control over privacy, but it also has some downside.
Okay, the last question I'm going to pick, because it looks like we only have 1 minute left, is from Min Trin, and he or she says, I think a good question, is the FDA well-equipped to test and approve AI-based devices and treatments?
I would say no. The reason I say that is almost invariably everything they've reviewed is, with notable exceptions, is retrospective. And it's provided by the company with proprietary algorithms. And it's very inadequate to make judgments that are going to be at scale for patients and could potentially cause harm. So I think the other thing, of course, is that they freeze the algorithm. So the autodidactic nature of deep learning is completely lost. And so we basically have, quasi-validated and then frozen algorithms. This isn't good.
I think that's well said. And I happen to know that several people at FDA tend to share your perspective. So, Eric, you've been great. Matthias, I hope you're pleased. I'm sure the audience got a lot of it out of it. And I think we're at the end of the hour. So Matthias, take it away.
Yes. For me, it's only left now to say thank you, Eric, and thank you, Zak, for this amazing discussion, for this great presentation. I'm sure the audience loved it, and it will be available online for anyone to look at. Thanks to everyone involved, the participants, the partners, sponsors, and the co-community in Switzerland. And just one last thing, we'll have another amazing webinar next week by Matt Langreen, who joined AWS from Stanford, on the gift from yesterday, medical data as a public good, which I think is a great next webinar after today's discussion. Thank you again. Have a great rest of the day. And
thanks all.
Bye.
Thank you.